Thank you, Ellie. Good morning and welcome to day 3. We've had some excellent sessions over the past 2 days, and we surely hope you've learned a lot from all of the experts that have been willing to share. All of the session recordings from both days 1 and 2 have been uploaded, and you can watch those by using the agenda feature. So if you've missed something, it's not too late. You can go take care of that and catch up. We want to thank our sponsors. If you haven't yet, as Ellie mentioned, they have booths available, and we hope that you at least wants to kind of bring. The token hunt has been very popular. Winners of the prize drawing from day 2 are Hannah Hansen from On Point Health Data, a NAHDO featured partner, and Ahmad Yassin from Chia, also a NAHDO member. They won $50 gift cards. The final drawing is this afternoon. It will be for another $50 gift card and a $250 gift card, or you can use that as credit towards a future NAHDO event. So make sure you've got at least one chance to win by entering at least one token. We also recognize NAHDO strategic partners. These NAHDO members provide extra support to NAHDO initiatives, including the APCD Council, Data Quality Forum, and other efforts. Thank you so much for being a strategic partner. If anyone is interested in learning more about how to be a strategic partner, please contact me. And now, one last chance for me to remind you to save the dates. August 14th to 16th, 2023, our in-person event in Boston. We are really looking forward to meeting you in person. At this time, I would like to present 2 NAHDO awards. First, the NAHDO Data Pioneer Award. Over the years, NAHDO has given awards that recognize an individual's contribution to data use or programming at a NAHDO member health data organization. In 2021, the NAHDO board established the name Data Pioneer for this award. NAHDO is pleased to award Ray Campbell with the Data Pioneer Award for 2022. Ray has been the executive director of the Massachusetts Center for Health Information and Analysis, or CHIA, since 2016. CHIA is the state agency responsible for the all-payer claims database, inpatient discharge database, and other health data sets that are essential to the state's efforts to improve quality, efficiency, and transparency. Ray is an attorney with extensive multidisciplinary experience working in senior positions with public sector and nonprofit organizations on issues that intersect law, technology, and health data. Also, public policy and strategy. Prior to joining CHIA, Ray served as the acting executive director of the Massachusetts Group Insurance Commission, the agency that provides life, health, disability, and dental and vision services to the Commonwealth's employees. Ray first became involved with NAHDO in his role from 2005 to 2012 as the executive director and CEO of the Massachusetts Health Data Consortium, or MHDC, a multi-stakeholder nonprofit comprised of virtually every organization in Massachusetts that is active in using health IT and health data to improve healthcare. Let's hear from Ray, his acceptance remarks for today's award. Ray?
Hello, everyone. My name is Ray Campbell, and I'm the Executive Director of the Center for Health Information and Analysis, and I want to thank NAHDO for giving me this year's Data Pioneer Award. I am very honored and grateful. It has been almost 17 years since I attended my first NAHDO conference in December 2005, and I've been a big fan ever since. As a reflection of my enthusiasm, my agency, CHIA, has almost 90 people attending this year's NAHDO conference. I think there's tremendous value and peer-based knowledge exchange in the areas of health data and state health policy. I also want to thank my co-workers at CHIA for the incredible work they do, for their support during my time as executive director, and for their friendship. You are an amazing collection of talented people. The work you do is interesting and important, and you make the Commonwealth a better place to live and raise a family. In many ways, this award is for you as much as it is for me. I also want to thank the godfather of health data in Massachusetts, Lou Friedman, and my predecessor at the Massachusetts Health Data Consortium, Elliot Stone, for paving the way for the work I have been so fortunate to do. Jonas Salk once said, the reward for work well done is the opportunity to do more. And so thank you for this award, and it's back to work.
Thank you, Ray, and congratulations. For our next award, since 1990, this is our NAHDO's oldest award, NAHDO has presented the NAHDO Award of Excellence in Health Data Leadership to one or more individuals who represent the highest ideals in data collection, analysis, or outcomes measurement, and whose creative efforts have made outstanding contributions to improvements in the collection, application, and/or dissemination of health data. Until his passing in 2005, Elliot Stone helped select awardees who made significant contributions to the health information field and who exhibited characteristics of quality, excellence, and passion in their work, characteristics that Elliot himself embodied. In 2005, following Elliot's untimely passing, the NAHDO board renamed the annual award as the Elliot Stone Award of Excellence in Health Data Leadership, in honor of Elliot and his acknowledgement of his generosity, care, and diligence to the field and to his colleagues. NAHDO is pleased to present the 2022 award to Anna English. Anna is the president and CEO of the Colorado Center for Improving Value in Healthcare, or CIVIC, and has announced her retirement effective at the end of the year. Anna joined CIVIC in 2014, and under her leadership, the organization has grown considerably in supporting change by enhancing products and services, expanding public reporting, and increasing overall revenue. During Anna's tenure with the organization, CIVIC worked to make the Colorado APCD a leading resource among state APCDs while innovating its utility and expanding support services in Colorado and across the country. Anna, let's hear from you.
To the NAHDO family, board of directors, staff, members, and associates, who I consider my friends, partners, and colleagues, I am humbled and honored to be recognized by such an incredible group of leaders in the health data community. Your expertise, ingenuity, and fearlessness is shaking foundations, building bridges, and forging frontiers of health data collection, analytics, and utilization across the country. I am consistently awed by not only what the CIVIC team has created, but by what each of you have accomplished. To have been a part of the NAHDO family is one of the highlights of my career. If there is anything that I've learned during my time at CIVIC is that health data is a team sport. The sheer scope and breadth of the field ensures that no one person or organization can expect to do it all. Strong partnerships are vital when data moves at the speed of trust, and you're releasing community-based or named facility, provider, or payer analytics designed to spur the shift to affordable and high-quality healthcare. Trust and confidence in the data are paramount when plans for vaccine distribution are needed in the middle of a pandemic. Computer scientist Kurt Bolliker observed, "Data that is loved tends to survive." It has been my experience that he is so right. Many of us have been in this game for a long time, a really long time for some of us. And the drive for more information, more evidence, more data is increasing every single day. Organizations like NAHDO, the APCD Council, and all the members have been and continue to clear the paths, ready to push forward, to strive further, and to transform healthcare in America beyond our wildest dreams. Thank you again for this great honor. It has been a privilege to not only be a part of CIVIC, but also a privilege to work with each one of you. Thank you.
In recognition of this award, NAHDO presented Anna with a lighthouse wind chime. This has deep symbolic meaning. In addition to the connection to Elliot M. Stone's New England ties, the symbolism of the lighthouse itself is a powerful witness to Anna's leadership and accomplishments that have guided so many others along their journey. Congratulations, both Anna and Ray. At this time, I would like to introduce today's opening plenary, a panel discussion with federal officials. This session was organized by Nicole Fawcett of VHI, who will moderate today's panel. The session is sponsored by Barry Dunn, a NAHDO featured partner. I will now turn the time over to Jeff Stoddard from Barry Dunn for some introductory remarks, then we will welcome Nicole and the panelists on stage.
Good afternoon, and welcome to this plenary session moderated and organized by Nicole Fawcett of VHI. My name is Jeff Stoddard, and I am the co-leader of the Data Management and Strategy practice within Barry Dunn's Health Analytics Practice Group. We work with state governments and not-for-profit healthcare organizations to provide data management, analytics, health policy, and Actuarial Services. We're pleased to be a sponsor for this session and look forward to connecting over the course of the conference. Thank you.
Thank you, Jeff, and thank you for those remarks. I'm now just going to hand it off to Nicole to introduce today's panel and to get us kicked off. Nicole, take it away.
Great. Thanks so much, Norm. Well, hello, everybody. Welcome to this federal panel. We're really excited. We have some absolutely astounding members on the panel today. It's going to be such an enriching conversation, and we're so excited. So with that, I'll introduce all of our panelists, and then we'll get started with their great content. So first, we have Micky Tripathi, who's the director at ONC. Also joined by Allison Oelschlaeger, who is the Chief Data Officer and Director of OEDA at CMS. As well, we have Dr. Jennifer Layden, who's the Associate Deputy Director for Public Health Science and Surveillance at CDC. And we have Lucy Dalzell, who's Survey Director of the National Ambulatory Medical Care Surveys at US Census Bureau. So thank you all so much for being here. We're so excited to have you all together to just share with us today. So the topic that our panelists will be covering is the future of health data from the federal perspective. So I think to start off, we're going to give each one of them an opportunity to share their remarks on that topic, and then we'll go from there. So I suppose we'll start with Micky.
Okay, great. Thanks, Nicole. Hi, everyone. I'm Micky Tripathi. Really delighted to be here, and I want to thank NAHDO and the entire community for the opportunity. I would be greatly remiss if I didn't begin by congratulating Ray Campbell on the award. I've known Ray for many, many years in Massachusetts, and he was actually my boss as the chairman of the board of the Mass Health Collaborative that I had the privilege of running for a number of years. So very richly deserved award, and want to congratulate Ray. So I'm, at ONC, we've got a whole bunch of things going on that I would, sort of characterize as trying to do everything we can to create an open architecture system for the sharing of data so that federal as well as non-federal business owners can actually do the great things that they want to do. And I think, look at my colleagues and my partners here, like Jen Layden from CDC and Allison from CMS, and a little bit less with Lucy from the US Census Bureau, but Lucy, we're happy to support you too. As, sort of the business owners, as the people who have mission focus in very specific areas: quality measurement, payment, public health. And what we want to do is say how to create the open architecture ecosystem of health information technology and data liquidity to enable them to not have technology be the barrier to their being accomplished what they want to be able to accomplish, and allow them to innovate on top of, sort of these open platforms and open systems in the ways that they need to get the best, end user applications, the best data mobilization to be able to take the kinds of actions that they want to be able to take. And the same applies to private sector actors as well, as we think about anyone in the private industry being able to have, appropriate, secure, privacy protecting access to information for them to be able to innovate and deliver greater value to the entire system, as well as to patients at the end of the day. I would point to just a few key initiatives, and those are all directly supportive of work that the Jen and the CDC are doing, as well as work that Allison and CMS are doing as well. So happy to sort of make those connections as well. I think of it in three layers. One is the data itself. So the US CDI that many of you may be familiar with, the US Core Data for Interoperability, is now sort of in many ways is kind of the minimum data set of the healthcare delivery system. It's required to be supported by EHR vendors across the country. The vast majority of providers use certified EHR systems, so they're using systems that are required to support that minimum data set. And working with our federal partners, for example, like CMS and CDC, we've been building on that US CDI to say, how do we sort of enhance or enrich those data sets, that minimum data set, to be able to support their very specific needs in a way that allows everyone to say, we're going to start with the same base, that allows us to leverage what the healthcare delivery system is already used to and capable of, but allow it to sort of have that additional focus on the very specific public health and quality and payment needs that that our federal agency partners have as well. So that's a core construct, and we're doing everything we can to expand that US CDI, both, as I said, with initiatives like the US CDI Plus for public health and for quality that allows us to extend from that, but also to make sure that it incorporates key, societally important kinds of dimensions like social determinants of health and health equity related information as well. Everything from disability status to cognitive status to race, ethnicity, language, to social determinants of health categories. All of those things are things that we've added recently to the US CDI to ensure that it's covering is everything we want to be able to do from a health equity perspective. Second thing I would point to is FHIR APIs. For those who aren't familiar with FHIR, it's basically a modern internet approach that you use every single day on your iPhone or your Android phone to be able to access information from Amazon or ordering food from using Uber Eats, and using that same technology across the healthcare ecosystem to have the kind of functionality and the kind of usability that we have in almost every other walk of life, and bringing that to healthcare delivery and to public health as well. So by the end of this calendar year, all EHR vendors are required to make available to their customers a standard FHIR API for the access to the US CDI data set. And that'll be a really important threshold for the industry, because that means the entire industry will now have a standard FHIR API that everyone can count on being able to access that information to get that US CDI data. And as I said, we're working closely with CMS and the CDC on saying, that's great. How can we now start to say, how are we going to leverage that to be able to do the things that we want to be able to do from a US government perspective, better, faster, cheaper than we've been able to do, to date. Finally, TEFCA, the Trusted Exchange Framework and Common Agreement, nationwide network interoperability. Many of you may be familiar with the private sector networks that already exist today, which have done tremendous work in getting interoperability among providers for treatment purposes. But we've seen that those have started to slow down, because as private sector initiatives, they start to confront issues that are too hard for the private sector to manage on its own, like competitive issues, like issues that are really public goods, like public health, for example, that hasn't been able to participate directly in these networks, and like payment. Payers have not been able to participate directly in those networks. So with the federal government participation in TEFCA, which we launched in January of this year, and we are looking forward to, in the first quarter of 2023, announcing the first qualified networks that will have made it through the approval process, that will start an implementation cycle that by the end of 2023, we'll have the first network nodes of TEFCA, sort of up and running. So we're very excited about that, and we're working very closely with our federal partners to develop public health oriented use cases and payment oriented use cases, as well as individual access to be able to have the kind of network capability that all of us expect from our healthcare system. And as I said, all those things are directly supporting, I think, some of the things that Jen is going to talk about from the CDC as it relates to the North Star architecture of the DMI. Thank you.
Great. Thanks so much, Micky. I definitely have multiple follow-up questions, as I'm sure a lot of our listeners do as well, to kind of dig into that a little bit more. So I guess with that, it probably makes sense for us to pass to Dr. Layden. If you want to give opening remarks as well, that would be great.
Great. Can you hear me okay?
Yes, we can hear you.
Okay, great. Really, it's hard to follow Micky. But I will try to do my best. Echoing what he says, it's really great to be here, and thank you for the opportunity to be part of this panel and to have this engagement with you all. I serve as the Associate Deputy Director for Public Health Science and Surveillance at CDC, the office that oversees the DMI initiative. I actually worked at the state and local level for many years, and so I'm bringing that perspective of what's needed and where the pressure and pain points are in our public health data ecosystem at the state, local, and federal level. DMI is an agency priority, and it's a national effort that we are doing in collaboration, not only with our still partners, really trying to extend those partnerships with many other entities, healthcare systems, healthcare vendors, private partners, academia, our federal agency partners. Our goal is really to ensure that those that need data, whether it's at the state and local level, community members, individuals, have access to data for better, faster, actionable decision. We have challenges across our public health ecosystem with the ability for data to move quickly, to exchange it quickly, and to ensure that we visualize it, disseminate it, get it out there for those to use the data and see the data make decisions based on what's there. So the overarching goal of DMI is really to improve that data exchange, data sharing, data analytics visualization to improve and inform decision. It is a long-term transformation that we need to make across our ecosystem, as I think we've seen during the COVID and monkeypox and recent responses, is that our systems have not worked effectively. We need systems that can communicate and talk to each other and exchange data and support the needs of those that are using it, whether it's at the state and local level, CDC programs, those in healthcare sectors who rely on that data. One of the key things that we are working on is something we refer to as the North Star architecture. We know that data is used by multiple individuals, and with the advances in technology and opportunity to leverage policy in health IT standards, we want to establish that blueprint for that future state public health ecosystem, which we refer to as the North Star architecture. It defines or helps us to describe how the data flows and information systems are coordinated, interoperable, connected across not only our public health systems and programs, but also with our healthcare partners. Since it's a common framework that we can use to help guide our decisions, both short-term and long-term. We want to rely heavily on standards and interoperability, working closely with ONC, other federal partners, as well as healthcare, to take lessons learned in other settings and apply them to our public health system. This has been an effort that we've worked on with our partners, including Micky and his colleagues and team at ONC. We've had input not only from states and locals, but healthcare technology vendors, healthcare industry, and many public health associations. By having this blueprint, it enables our programs at CDC, our state and local partners to make informed decisions. One component of this is providing shared services or tools or resources that can be used across jurisdictions. There's wide variation across all of our public health systems in the nation as far as what their capabilities, both short and long term. And so we recognize we have to meet jurisdictions and programs where they're at. So building up shared services, having a essentially tiered model of support for jurisdictions, whether it's more relying on more centrally hosted services and systems, or having a hybrid model in which state and locals can identify what they most need and have access and leverage those resources, or the local, state, and local hosting systems that work interchangeably with this North Star architecture. Overarching goal is to help streamline those activities, solve problems, to really ensure that we can get the data that's needed, not just for responses, but for programmatic needs, case investigation at the state and local level, as well as so many other needs to inform decision. There's many objectives and key features of this North Star architecture, and working very closely with ONC and some joint priorities. We're very excited about the opportunity for TEPCA in public health and looking to identify that short and long-term strategy and identify those public health use cases. In doing so, working closely with our programs here at CDC, as well as with our state and local partners. We see the potential for the North Star architecture to help reduce the burden of reporting data to CDC. Also report the burden, or reduce the burden, of those working in the field. We know that there's a lot of manual time spent cleaning data, aggregating it, linking it, and there's tools that can help. And we want to develop those shared tools that can be used at all levels of public health. So reducing the burden of reporting, reducing the burden of those working in healthcare systems, and making our systems talk to each other, making them harmonized and able to share data, exchange data. A key component of it, as I mentioned, is building up these shared services, or something we call building blocks. Tools, modules that can be used for multiple purposes by different systems in different jurisdictions, and making them available to support the needs and prioritizing the building blocks based on the needs of our partners. So with that, I'm really excited about the future and promise of DMI to improve our data exchange and data sharing, not only at CPC, but with our partners, and look forward to the rest of this conversation. Thanks.
Great, thank you so much. Yeah, we definitely look forward to digging into more details on DMI as well. So I suppose with that, I'll also next pass to Allison.
Thanks so much, Nicole. It's great to be here with the NAHDO at the NAHDO conference. I love this event because it's great to hear from our federal partners and have the opportunity to share with all of you, but also to hear questions and just what's going on at the state level. There's a lot for us to learn. So obviously, as everyone knows, CMS is a massive organization and we oversee healthcare services for a huge population. We're up to 156 million Americans that are enrolled in one of our programs, whether it's Medicare, Medicaid, or the marketplaces. We have oversight of healthcare safety and quality. We do program integrity. We have alternative payment models that we run to try to think about the future of healthcare. And so doing all of that work, we collect a massive amount of data, and we also oversee, kind of regulate the use and sharing of data across the healthcare industry. And so as we've been thinking about the future of health data, we really see the importance of stakeholders across the healthcare system having access to the data that they need to make decisions. And it's even, CMS has 13 cross-cutting initiatives, and one of our cross-cutting initiatives is data to drive decision-making. So that shows you how important it is to the administrator and to the entire team at CMS that we're using our data effectively and sharing our data and encouraging the seamless exchange of data across the healthcare system. I wanted to focus kind of in two areas as I talk about how we're thinking about the future of data. The first is internally. So we've taken this initiative and we've said internally, what are we doing to continue to facilitate use of data within CMS as we're making decisions? So one of the key things that I think everybody across the industry is dealing with is modernization. So for CMS, that's everything from looking at our fee-for-service claims processing system and saying, how do we modernize this? How do we make the data kind of flow through CMS more smoothly and get out of COBOL programming and into more modern tools? It's also things like moving to the cloud with our analytics platforms so that we can do more advanced analytics, more machine learning type work as we think about really driving forward with decisions on our programs. Speaking of machine learning and artificial intelligence, that's another area that we're continuing to think about. How do we expand? How do we explore more? We've historically done work in kind of fraud detection and prevention related to using machine learning techniques, but we're starting to think about how do we use those tools in other parts of our programs. Another thing that I think is common across feds and states is how do we continue to break down silos, even within CMS as we look at our data analysts and our data kind of programs. We have just silos where information doesn't get shared or activities are duplicated because people don't know what's going on. And so continuing to think about and build programs around building communities of practice around our data users and sharing knowledge about the work that we're doing related to our data so that we can be really effective in using our data and sharing our data. And then finally, internally, obviously health equity is a huge topic across the healthcare system. It is a very key priority for CMS. And I think we talk about health equity from a policy perspective, but we also really need to think about it from a data perspective. And are we building a data infrastructure that can support us using our data and understanding how our programs and policies are impacting health equity? So we've published a framework for advancing health equity, and priority one of that framework is expanding the voluntary collection, reporting, and analysis of standardized demographic and social determinants of health data. So this will allow us to increase our understanding of disparities across our programs and the needs of those we serve, so that we can really be making decisions that kind of understand and reflect the total experience of everyone in our programs. As I look externally and kind of how we're promoting innovation and encouraging patient-driven care, we're thinking about how do we drive data transparency and how do we encourage the seamless exchange of data across the healthcare system. So one of the things that we're doing is continuing to think about our public data products. So that's data.cms.gov, which is a great resource if you're looking for publicly available CMS data. We have a ton of data products out there, but are continuing to think about how do we make more products available on data.cms.gov? How do we make data.cms.gov the experience seamless and easy for folks to find the data that they need? Data.cms.gov leverages APIs that Micky mentioned earlier. So there's lots of ways to access the data, whether you want to go into the site and view the data yourself, or you want to have an API call and just be able to pull the data as it's refreshed. Lots of options, lots of documentation. We're also continuing to think about how we expand data sharing with the broader research community, and recently announced a new suite of data files that cover alternative payment models run by the Innovation Center. So this is files that have both provider information and beneficiary information for providers and beneficiaries that are participating in alternative payment models. So lots of great data there that can help researchers really start to dig in to what's happening with the great work that the Innovation Center is doing. Another important flag for the state APCD folks that are in the room is that on Monday, we rolled out some changes to our research data request forms. Really, we took a look at all of the forms and said, we're collecting some duplicate information, and there's, the forms just had evolved over time. And so we took a look and really tried to streamline and simplify things to make it easier for folks who are going through the research request process. Micky mentioned FHIR APIs. CMS has a suite of FHIR APIs that we're continuing to expand and grow. Blue Button 2.0 is our API that allows beneficiaries, Medicare beneficiaries, to access their own claims information. We have something called BCDA that is for alternative payment models. So ACOs and other CMMI models who want to get data it's a bulk data feed. So data on a population of patients that are aligned or assigned to the model. A and B to D is our API for Part D plans that want to get fee-for-service claims data for beneficiaries who are in a standalone Part D plan. So the Part D plan can understand the healthcare services that the beneficiary is having. And then data at the point of care is a pilot that allows providers to request claims data for their population of patients. And that idea is really having the data integrated with within the EHR, so the provider has it kind of at their fingertips to see past lab work that's been done, or imaging work, or understanding a beneficiary's full suite of prescription drugs that they're taking. And then as we think about, so that's all the things CMS is doing to share data, but as we think about data exchange within the healthcare system, we're also doing a lot of rulemaking and kind of policy work there. So we have our patient access and interoperability rule that talks about how other stakeholders within the healthcare system have to build FHIR APIs, like the work that CMS is doing. And a flag that I wanted to mention for everyone is that we recently put out a request for information on developing a national directory for providers and services. So would love feedback from folks in the room, and please share it widely. Comments are open until December 6th. So we're really looking to get feedback on the idea of building some sort of national directory, which would be a huge undertaking, but we think is needed within the healthcare system. So with that, Nicole, I will turn it back to you.
Great. Thank you so much, Allison. Some really great information that you provided. So thank you. And I guess we'll round out introductions with Lucy. Go ahead, Lucy. Lucy, I think you might be on mute. Just give her a few minutes. Okay, we'll give Lucy a few minutes. So I guess to kind of work back through while Lucy is engaging with her issues. Sorry about that, Lucy. I want to go back to a few comments that were made just with the introductions that we've gotten so far. I get the impression that, obviously like ONC and CDC and CMS, there's a lot of collaboration there, and there's a lot of, seems to be a lot of projects that you guys are sort of joining forces and working on together to make sure that you're presenting this united front, and to make sure that you're all just communicating to ensure that, there's a one solid path forward. And so I want to dig into some of those programs a little bit more. So one of the questions that I have, I guess I'll start with Dr. Layden. I wanted to ask, in your sort of description of the DMI, you kind of talked about how it's a long-term transformation, right? Like it can take several years to kind of set up a digital transformation like that. I think that the folks who are listening might be interested to know what are some of nearer term examples of the value that you expect DMI to deliver in terms of like health data and how that can become actionable for people.
Great, thank you for that question. And you raised a really good point that the digital transformation is, and necessarily will be a long process, but there's importance for a variety of reasons to show those near-term examples, success stories that will help show impact and value, build the trust, build the collaboration, and build that support for the ongoing efforts and needs to maintain dedicated resources. And there's probably a couple ways to look at this. One is based on areas that we're prioritizing or focusing on, as well as kind of some overarching principles that would be applied across systems and that we're working with in centers and partners. From a data source approach, the case data and ECR data is a high priority. We've seen the value increase acceleration of the use and adoption of ECR, which is that meeting earlier today with some of our state and local partners in one jurisdiction talked about how they used ECR to identify long COVID cases, and they really were able to pull in information that helped in that effort. We also are working with colleagues on modifying our case reporting and notification, how we reduce the burden, how we have some standardization across all of our jurisdictions. So we have consistent core data that is being transferred and exchanged across it, especially for in times of emergency. We are also emphasizing the importance of data sharing, open data, getting the data out there, whether it's through visualization, making it available through open data sets, emphasizing that not only with CDC, but with our partners. So this includes the release of data from some of our core data systems, so they can be used by various different partners, getting data back to our states and local partners, especially when they're so much at the forefront of using that data and collecting the data, getting data better back to our healthcare partners and others, in formats and mechanisms that are useful for them. We have seen some successes in that. Look at some of the work in healthcare-associated infections in some jurisdictions and health departments that have been able to have bi-directional exchange of data that really helps to drive clinical decision-making. So across our systems, focusing on reducing burden as well as getting the data back out there. But to emphasize some of the core areas of focus, recently have been on the case reporting notification, including electronic case reporting.
Great, thank you so much, Jen. And we will go back to Lucy so that she can kind of contribute to our topic so that we can start her off as well. Well, I'll put a pin in it because I think there's other questions that I can ask to sort of support or elaborate on what you just said, Dr. Layden. So thank you. And obviously, if anybody has questions, follow-up questions or additional questions to what Dr. Layden described, feel free to put them in the chat. So we'll put a pin in that and I'll hand it back over to Lucy. Lucy, hopefully we can hear you.
I think you can. Is that right?
Yes, we can. Yes. Go for it.
Okay. Good afternoon, and thank you so much for having me. It is a real honor for the Census Bureau, which is a federal statistical agency, to be included here along with the premier federal health agencies. In the spirit of sticking with good standards, the Census Bureau is having me include the disclaimer that any opinions and conclusions expressed herein are those of the authors and don't reflect those of the U.S. Census Bureau. Okay, that box checked. I'd like to start with a story. The other week, I took my 12-year-old daughter for her annual brain MRI. The appointment was at a facility that we know well and has provided her with excellent care over the years. On this day, we arrived on the second floor for her MRI. We were asked her height, weight, and current medications. We then proceeded to the MRI, which went smoothly. We stopped for a snack and then went to the first floor of the same facility to meet with her neurosurgeon to discuss the results. Upon arriving on the first floor, we were again asked her height, weight, and current medications because their records reflected the information that we had provided the previous year, not what we had provided one floor above the previous hour. This was despite the MRI images and the radiologist's report had made the transfer down from one floor to the other. Her neurosurgeon also had reviewed the results and was ready to meet with us. Thankfully, it was a clean report. This experience stuck with me as a vignette of what we see so often within and outside the world of health data. As a society, we've pulled off some incredibly challenging technical feats. I'll offer the MRI here as an example. The logistics around the effective use of that technology can be challenging in their own right. In this case, having the reports from two highly trained specialists within an hour of a non-emergent MRI is quite impressive. Why then is height, weight, and current medications not shared from one floor to the other? In this example, I thought the impact was pretty inconsequential, so I didn't even mention it at the time. In retrospect, though, we could adjust some details of that case and find that it could be consequential for one department to know the current medications reported to another department. At the Census Bureau, we have a relatively new program called the Enhancing Health Data, or the eHealth program. You might have heard us talk about some current projects on Tuesday. The purpose of the eHealth program is to strategically reuse existing data to gain insights on patients, providers, and population health. At the Census Bureau, we're mandated to reuse existing data to the greatest extent possible to reduce respondent burden and measure and analyze relationships. The Census Bureau houses demographic and economic data that are extremely valuable to understanding the social determinants of health and the business of healthcare. By partnering with external curators of health data, we can securely ingest and link health information to individual level records of people and businesses. Navigating our agency's robust disclosure review process, we protect the identities of individuals and businesses and release to the public summary level findings that neither the Census Bureau nor our partners could produce on their own. I want to emphasize confidentiality is very much baked into every aspect of what we do. In fact, the Bureau's legal authority demands that it provide the strictest protection of respondent data such that there can be no chance for someone to be re-identified in the data that we release to the public. For us at the Census Bureau, we're like that MRI department with valuable information that could potentially improve health outcomes through collaborative efforts. There's many challenges ahead for all of us working in this health data space. Not all improvements are necessarily technologically difficult. In my story, the particularly challenging things are done. The MRI was invented, it was accessible to the patient, and we had experts available to read the results. The rest of the story required no novel innovation or new scientific discoveries. Instead, it depends on better coordination, open discussion, and a joint commitment to making things better for the patient. It's not always easy, but we know it's possible if the will is there. At this point in eHealth's history, we've partnered with federal agencies, state governments, and nonprofits. The common denominator at each of these partnering organizations is having at least one person who is what I call a possibility thinker. A possibility thinker is a person who sees how things could be and what steps would be needed to achieve that. Each of the organizations that we partner with has at least one person who feels the health information that they curate would be more useful by securely linking it to other data sources within the Census Bureau. You're here because your organization believes in improving healthcare data collection and use. My question for you is, do you see opportunities for making such improvements to the data under your care? Could those improvements be made in a way that respects confidentiality? If so, what would it take to make your vision a reality, and are you willing to see it through? For the eHealth program, we found it often isn't a matter of having a large number of people with the same vision. It's just having a couple that feel strongly enough about their idea that they'll champion it and make it happen. Could you be one of those people? If so, I'm fairly certain that you'll find like-minded people among the participant list at this conference. If you're interested in learning more about partnering with the Census Bureau, I and my colleagues who presented on Tuesday are more than happy to chat. And thank you again to NAHDO for this opportunity to participate in this illustrious panel. I've already taken numerous notes of what you all have said, and now I'll turn it back to Nicole.
Great, Lucy, thank you so much. It was great to be able to hear from you. And I actually, before we pass it back, I actually do want to ask you a question. You mentioned having one or two people, you call them the possibility thinkers, right? At each partner organization to be able to establish a new project, such as like the eHealth one that you were talking about. And I'm sure, in my experience somewhat, as well as like, I'm sure the experience of a lot of the folks who are listening, is that there are usually quite a few people that are needed to approve a data sharing agreement and like get their hands dirty and make it happen, right? So can you elaborate a little bit more on what you mean when you talk about that dynamic?
Yes, thank you. Yes, so we're as the Census Bureau, which is as we mentioned, a federal statistical agency, we are somewhat new to the health data space. The role of the federal statistical system is to be of service to program administrators, to policymakers, and the general public. And as such, our goal is to provide data that are as relevant to folks in those roles as possible. And we're finding that in the health data space, the contributions that the Census Bureau could potentially make are not as well known. And so what our approach that we have been taking is that with organizations that are interested in potentially collaborating with us, there usually is, as I mentioned, one or two people that would really like to learn more about the Census Bureau processes and talk through the potential use cases of and what the expected benefits would be out of that. And in those conversations, there are still a number of people back at their home organization that yet still don't know much about the Census Bureau and how that collaboration would work. And so the role of that possibility thinker would be to build a relationship with the Census Bureau and also with their home organization, and the relationship building of that partnership. That's one of the key lessons learned that we have come across in the 6 or 7 years of history of eHealth, is that relationship building phase cannot be abbreviated or rushed. And it's really paramount for building those ties and those mutual understandings of what the expectations are. And that is one of the key roles of those possibility thinkers. Thanks.
Absolutely. Thank you. Yeah, of course, it always has to start with a relationship, right? And I think earlier on, we kind of heard about how, I think it was in Anna's acceptance speech of her award, she was talking about how like data can only move at the pace of trust, right? So, and that starts with relationship building. So absolutely. Thank you so much for your feedback. I actually want to jump over to Allison because I wanted to ask her something that kind of ties a little bit, Lucy, to a comment that you made. So Allison, and there are multiple questions in the chat for you as well. I would imagine, a lot of the NAHDO members, as well as organizations that are probably represented, most likely have a very direct relationship with CMS, particularly if they are, APCD administrators and such. So it's not surprising that there are a lot of questions for you. We'll get to as many of them as we can. For now, though, I wanted to ask, as we kind of think about the future of healthcare data, and again, like Lucy sort of alluded to this aspect a little bit, we often talk about more data sharing being the path forward, but can you talk a little bit about, like, from your perspective and like the CMS perspective, what that means in terms of patient privacy? Because that always tends to kind of be this correlating factor or maybe even concern that comes up when we talk about, more data sharing and transparency.
Yeah, absolutely, Nicole. And thank you for this question. When Lucy was speaking about confidentiality, I was like, I hope I get to jump in and talk about our perspective on this, because I think given all of the data that we collect and oversee, privacy is such a critical issue for CMS, especially when you think about the population that we have that includes really vulnerable people. And so ensuring that data is protected, secure, private, confidential is really critical for us. And I think there are a lot of tools and techniques out there that we have been using. So wanted to touch on those briefly. So a lot of you access CMS data as a research through our research pathway. And when we do physically share data with researchers, we've been encouraging a lot of researchers who don't have massive amounts of data that they're linking, like APCDs, but researchers who are really just using the Medicare data or connecting it to other kind of publicly available data sources or smaller proprietary data sources, to use our virtual research data center, which is a enclave-like environment where researchers can virtually connect into the CMS data center, access the data that they're approved to use, do any analyses that they want to do. We have SAS, we have Databricks platforms, so lots of different analytic tools that people can use, and then take out aggregated results. Lucy mentioned confidentiality, and the Census Bureau just does fantastic work on de-identification and synthetic data. And so as we're having researchers take data out of the VRDC, we want to make sure that the data is de-identified and meet CMS's policies around cell suppression for small cells. So that's one thing that we're doing. I also mentioned synthetic data earlier, and the Census Bureau has been driving a lot of the work on synthetic data, but CMS has also been thinking about synthetic data. And for our FHIR APIs, we have sandboxes that allow application developers to connect in and access synthetic data before they get access to the production environment. This means they can build an application, they can build a connection, they can kind of play around with the data with using something that looks like real claims data, but doesn't reflect any real patient information. And so we've found that synthetic data has been really beneficial in allowing developers to just get their hands into the data, get their feet under themselves as they're building applications and tools without putting any patient information at risk. And then I also wanted to talk about privacy preserving record linkage as we think about data sharing within the federal agencies, also with external parties. This is not something that CMS has really dug into too much, but it's something we're starting to talk about across HHS is how can we use PPRL tools to help us do linkages without having to share any PII, any direct identifiers. And then also quickly wanted to mention issues around transparency and consent. The other thing that we really want to make sure that we're doing is being clear with patients about how their data is being used, and in some cases giving them choices around if their data is shared. So for example, beneficiaries that are assigned to a shared savings program ACO can opt out of having their data shared with the ACO, and some of them choose to do that. Also with our Blue Button API, beneficiaries have to give direct consent, and we walk them through a series of screens to make sure they really understand what they're doing by sharing their data with an application or service that they're choosing to connect to. So this is just such a critical issue, and I think it's something that we all need to continue to focus on and pay attention to as we move forward. Data sharing is so key, and it's the future of health data, and the future of healthcare, but we also need to make sure that we're really protecting patient privacy.
Yeah, absolutely. Thank you so much for such a robust response. I know we want to get to some questions in the chat if we can. Before we do that, I do kind of want to bring it back a little bit to sort of the collaboration and partnership between all of your entities. Specifically, Micky, I wanted to ask you, so the last sort of like program or initiative you mentioned in your introduction was TEFCA. And so I wanted to ask more specifically, it's and kind of tie it to COVID a little bit too, because like it's no secret, right, that COVID has had a massive impact on how we all think about and use healthcare data and IT infrastructure. And so we continue to sort of deal with the aftermath of like peak COVID, right? And so starting to think ahead, can you talk a little bit about the role that TEFCA can play in closing some of the gaps in public health that the pandemic exposed?
Sure, happy to. So I guess, a couple of, sort of pillars, I guess, as I think about, sort of how TEFCA can help to better serve the public health community and get through some of the barriers that we have with data sharing, and certainly welcome, Jen's thoughts on this as well. Are one, just as a general observation, I think one of the biggest challenges that we have with our public health system is, first off, it's not really a system. So there's one problem. And so we need to get more systemness out of our system, and network interoperability helps to do that, right? When you have distributed data across many jurisdictions and many different data sources, using networks through, governance, policy, technical mechanisms to allow that distributed data to be mobilized on demand for different purposes, with transparent governance about how that can happen is a core network function. And it's, served other parts of healthcare as well as every other industry, in fantastic ways. And I think bringing that to public health is really important. So that's, the first general observation. The second is one of the biggest challenges with our public health system is that it's that it and the healthcare delivery system are relatively siloed from each other. The connections that we have between public health and healthcare delivery are these brittle one-way messaging technologies that were literally created in the 1980s, and are not what we need to be able to have the public health system that really sort of envisions more of saying we have a healthcare ecosystem, and healthcare delivery and public health are just different aspects or different parts of a more integrated healthcare ecosystem. And one critical piece of that is for the public health community to be able to participate in the day-to-day networks that the healthcare delivery system uses, and to be able to leverage the technologies and the standards that are used by the day-to-day healthcare delivery system. So that's been a whole part of the focus and support that we've been working with Jen and the CDC team on, is to say, let's look at everything that we require of EHR vendors and of healthcare providers through CMS programs, through ONC certification, through all those other things. And how do we sort of more closely tie those to what the public health community needs, so that you have the ability to lower the burden or minimize the burden on the healthcare delivery system of providing information to the public health community, and the opportunity for the public health community, ideally, to be able to provide information back to providers, so that they see the value of it and the entire system is more responsive. TEFCA network governance, sort of enables those kinds of capabilities, because those are just four sort of core constructs of network interoperability: my ability to push information to any other participant in the network, my ability to query for information from any other participant in the network. The other two things I would point to is, one of the things that people may not be aware of, and certainly on this with these stakeholders, with data organizations, as well as anyone involved in HIE, it's a little bit surprising to realize that in public health we don't have network capability that allows jurisdictions to even talk to each other, which is is kind of amazing when you think about it. The way the public health system works is it's got jurisdictions who mostly send information. They have information themselves and they perform public health acts within their jurisdictions, and then they send data to the CDC under a certain set of terms, some of it de-identified through various mechanisms, but then it's aggregated with the CDC, and the CDC aggregates that and then shares it back in different kinds of ways with the entire sort of public health system. But if you think about, why don't we have on-demand capabilities for Oklahoma and Texas and Louisiana to just be able to share information with each other, right? There are certainly reasons that they need to be able to share information on demand to be able to be responsive. That's the kind of thing that TEFCA can support as well. When you think about a TEFCA public health interoperability capability, allow jurisdictions to share information with each other, as well as with the CDC, as well as individuals, as well as payers, as well as individuals. I already mentioned individuals. So as well as sort of all those other parties and entities, and be able to do it with transparent governance, which is what what networks offer.
Yeah, absolutely. Jen, did you want to add on to the comments?
Yeah, emphasizing, adding to this point about how jurisdiction systems don't often talk to each other well. That even happens within a jurisdiction. So we have many, many siloed systems that sit within programs. And those ability of systems to talk to each other is limited. So you look at COVID pandemic and the need to really understand where the breakthrough cases occur. That's data that's sitting in different systems, often in the same jurisdiction. And so getting to a place where not only we can share data across jurisdictions and critically with healthcare partners, but within our own systems. It was great with opportunity, and really encourage that about the opportunity to make TEFCA have help in some of these critical public health use cases.
Yeah, absolutely. Thank you so much. So those were all the questions that I had. So I guess we can, with our remaining time, we have about 5 minutes left. So I'll kind of transition over to questions that our audience has posed for the panel. The first of which says general question. So I'll just ask it and just kind of open the floor for whoever wants to answer on behalf of their respective agency. So Mel asks, as we standardize health data collection, use, and sharing in our backyard, are there any international/global standards used as either inspiration or a metric? And he says he's particularly thinking of current and future COVID research at the global level and how that data is shared.
Well, I'm happy to start because I don't have that much to say about it. No, I think it is really important. It's really important. Our focus has tended to be on, within the U.S. in part because, these interoperability kinds of issues are very jurisdiction dependent as you think about, sort of legal constructs and privacy laws and differences in privacy laws and conventions, sort of business practices and conventions, and the relative, the way that governments, sort of federal and local, state and local governments and the relative powers and authorities that they have differ so much across countries. You think about, the federal government tends to be very strong in European countries, relatively weak in the US, for example. So that just creates a whole set of differences in the way we think about interoperability and the way we think about data sharing and privacy laws and privacy protections. That said, for speaking for ONC, we currently chair the Global Digital Health Partnership, which is an international, a collaboration of countries from around the world that work on specific issues related to better sharing of information and greater consistency and adoption of global standards around the world. So we're have a number of initiatives there to start to think about specific use cases like what we call the IPS, the International Patient Summary, which is very similar to the US CDI that I was talking about before, which is in the US CDI is kind of that minimum data set of the healthcare delivery system. The IPS is very similar, and one might imagine that you as an individual might want a copy of your IPS as you travel internationally, for example. So if you have some healthcare event in another country, you could say, here on my iPhone, I have a summary of my medical record that's standardized so that EHR system in Singapore or wherever it is, for example, could almost seamlessly be able to, integrate that information. So there's, work being done there. I will say that, also the other element of it is that healthcare delivery systems are primarily work mostly within a country. I mean, you have some who Mayo Clinic has places in the Middle East and others, but mostly they focus in a country. For us, the biggest driver and the biggest requests that we get for the globalization of standards and for us to work more globally is from the EHR vendors. They're the ones who are who come to us and say, we have a ton of business in Europe now. We have a ton of business in Asia, and it would be really great if we could use the same standards, across all of those, countries and markets.
Yeah, absolutely. Thanks so much, Micky, for that response. I do want to mention, I want to open it up to the rest of our panelists if any of you would like to sort of give a response to Mel's question. Before doing that, though, because I know we're almost out of time with you all, which is so sad, I do just want to mention that there were a lot of questions for Allison in the chat. I've taken note of all of them as well as who asked them. So I will follow up with Allison offline to make sure that your questions get answered, just so you know. You're not being ignored, I promise. We're just almost out of time. So with that comment, I'll kind of pass it back to the panel if anybody else has wants to add on to what Micky just shared in response to Mel's question, or just would like to say anything to close us out.
I can add on just to the question about the international standards. That's, to me, very exciting to think about. I have just come from a federal statistical system conference and looking across the very diverse agencies that we have within the U.S. statistical system, along with what Micky was talking about, how there's quite a lot of silos even within the statistical system. There's still quite a lot of silos, and the conversations that I'm hearing there is trying to figure out how we can be more cohesive in our asking of questions that would be perhaps in support of COVID-related research. So how do we ask race and ethnicity in a consistent way? How do we ask what we call SOGI questions, sexual orientation and gender identity? How do we ask about that and do that across all of the different data collections that are done across government in a consistent way? So I think where we are, statistically speaking, is trying to get our own house in order within the U.S. and then thinking maybe a little bit more globally after that.
Absolutely. Yeah.
I will just add very quickly, because I know we're basically at time, but obviously CMS is largely focused on the US healthcare system. But one initiative that we are participating in is something coming out of OECD called Paris, which is a patient-reported survey that they're doing across OECD countries. So if you're interested in more kind of international activities, I would definitely check that out. And it's just been great being here with the NAHDO at the NAHDO conference again. So thank you so much for having me.
Thank you so much, Allison. Thank you all so much for your participation. It was truly such an enriching discussion. I'm really grateful for all of your participation today. And with that, I'll pass it back to Norm to close us out.